Good afternoon and welcome to this session on left atrial appendage closure. Is it evolving? It is. And are you ready for that? Your primary interest might be valves, but there's a lot of your valve patients that will also have atrial fibrillation, and some of them will not tolerate anticoagulation, and left atrial appendage closure might be an option for them. We just had in the main auditorium a session on combined mitral valve repair and left atrial appendage closure. So this is a summary slide showing that we now, within the field of LAAC, have got 4 randomized clinical trials, LAAC versus anticoagulation. The first one were Prevail and Protect, that was LAAC versus warfarin. Now we also have PRAG 17, an option which is against DOACs. And you can see the signal from those randomized trials are that LAAC has the same stroke preventative effect like anticoagulation, but there are less major bleeding when you do LAAC, and there's also a signal for reduced mortality when you go for LAAC. So probably those data have transitioned into an increasing LAAC activity. And you can see the upper curve is from the US registry on LAAC, and at now there are more than 500,000 LAA closure procedures done in US. If you look back in last year, it was 125,000 procedures, and in Europe 25,000. So this is definitely a highly increasing activity for left atrial appendage closure. So in this session, we'll try to address what are the unmet needs in stroke prevention for patients having AF, and how can we evaluate the latest clinical evidence, and what do the guidelines say about left atrial appendage closure, and what are really the patient population that can derive the greatest benefit from left atrial appendage closure. And we have a very esteemed faculty here, with Professor John Kam from London, Dr. Philip Garot Paris, Kasper Korsholm, Aarhus, Denmark, Apostolos Sikas from Greece. And it's now an honor for me to invite Professor John Kam here from London. He's really a pioneer within the field of atrial fibrillation, and really the father for all of us in this field. So please, Professor Kam, unmet need in stroke prevention.
Thank you very much, Jens Erik, and good afternoon, everyone. It's my job merely to set the scene. I'm not an implanter of the LAAC, but I'm very interested in atrial fibrillation. I'm very interested in stroke and atrial fibrillation, and I would like to cover the field for you very briefly, against which we can assess the evolution of left atrial appendage closure. So let me start by pointing out that, as usual, I do have some conflicts of interest. Most of these conflicts are related to professional societies, editing roles, and so on. But I certainly have been paid by various companies. Here they are, and amongst them is Boston Scientific, so please be aware of that as I speak. Let me start with some well-known issues just to set the scene. Stroke, 5 times more common in patients with atrial fibrillation. Warfarin reduces the stroke rate by 66% and mortality by 26%. DOACs, such as apixaban, further reduce strokes, major bleeding, and mortality. But there is a residual risk of strokes and bleeding. We can further help the stroke rate by treating comorbidities such as heart failure, diabetes, and hypertension. We have on the horizon new anticoagulants, and it's becoming increasingly obvious that the more we reduce the burden, that is the total time duration in which a patient is in atrial fibrillation, the less likely it is that a stroke will occur. Now, most patients, of course, are treated with an anticoagulant, warfarin or a DOAC, predominantly DOACs. But there are problems with anticoagulants. They're not completely effective. They do cause major bleeding, such as intracranial bleeding. They do have drug-drug and food-drug interactions, particularly the vitamin K antagonists. They do have reversal agents, but they're expensive or slow. And importantly, many patients do not adhere to therapy. Many physicians do not prescribe anticoagulants, and often the dose is not the correct dose. All major problems with warfarin and other anticoagulants. Here's an FDA-commissioned survey of DOAC drugs in the context of prevailing warfarin therapy. And you can see that thromboembolic strokes are significantly reduced. You can see also that intracranial hemorrhage is reduced by half. Major extracranial bleeding is increased with some DOACs, reduced with others, and the death rate is reduced by DOACs in comparison with warfarin. But the residual risks are significant. A 1% per annum thromboembolic stroke rate, intracranial hemorrhage in 0.5%, that's 1 in 200 patients, of course, major extracranial bleeding in 2 to 3%, and death in 2% of our patients. So with this in mind, often patients are never prescribed an anticoagulant. There are common reasons for this, which we all understand. They may be actively bleeding, they may have hypersensitivities, they may have severe liver disease, they may be pregnant, they may have severe thrombocytopenia or severe renal impairment. And then there are less absolute reasons, such as prior intracranial hemorrhage or major bleeding, uncontrolled hypertension or active peptic ulcer, concurrent medications such as NSAIDs or dual antiplatelet therapy. They may have a high risk of falling, particularly those with traumatic falls, and they may have extremes of body weight for which we're very uncertain about the dose of the anticoagulant. Here are some data from Garfield AF, the largest of the international surveys, 55,000 patients. 30% of these patients were never given an anticoagulant despite having a CHA2DS2-VASc score of 2 or more. You can see that the more the healthcare expenditure in countries, the more likely they were to have anticoagulants, and the opposite. The less the healthcare expenditure, the less likely to have anticoagulants. If we look specifically at the causes, we have paroxysmal atrial fibrillation rather than permanent, history of bleeding, primary care settings, old age, dementia, cirrhosis, and vascular disease. And around the world, even within Europe, you can see there are major differences in the utilization of anticoagulation. Patients, even if they're prescribed anticoagulants, often fail to take the medication. There are all sorts of relevant factors, particularly medication-related, such as adverse events from the medication, just having too big a pill, medical condition-related, such as asymptomatic patients or patients who have concomitant problems with depression, anxiety, people who don't think the problem is important, social and economic-related issues, such as a low level of literacy and education, a high cost of medication, and living in rural areas and unstable living conditions. Patient-related things such as knowledge, poor understanding, and so on, the fear of side effects, forgetfulness, cognitive impairment, common in atrial fibrillation, and mistrust, lack of support, poor provision with the healthcare system. So all sorts of reasons why lack of adherence may occur. What about dosing? Here are some more data from Garfield at the point when 35,000 patients had been enrolled, and you can see that if you look specifically at the patients on the left-hand side who were treated with the correct dose, the orange bars is between 70 and 80%. You can see low dosing, the blue bars is common, between 20 and 30%, and a few patients overdose. On the right-hand side, you can see the consequences of this. If you have high doses or low doses or non-recommended doses, you can see there's a major deviation with adjusted data or raw data from the line of unity, what happened with patients who took the appropriate dose. Now, how quick does a thrombus form? Many of us may think it takes months or years for a thrombus to form, but it can take only minutes. I just want to emphasize that by showing this case report. If you look at 3:57 p.m., the left atrial appendage arrowed on the slide has no clot within it. Half an hour later, at 4:27, there's a clot forming, and it's even more dense at 4:31. So 30 minutes and a clot can form. So people who neglect their anticoagulation are at high risk. Now, what about people who discontinue medication? Actually, in the Garfield study, it was only 13%. It can increase as much as 40 or 50%. You can see that only 3 reasons kept patients on the drug. It was either they were old, they had already had a history of stroke, or they had permanent atrial fibrillation. Discontinuation was very common, particularly with kidney disease and with events such as bleeding events. The consequences of the discontinuation you can see on the right-hand side, and you can see that discontinuing the drug just for 7 days is associated with very substantial outcome events in these patients. So let me conclude with this slide. Stroke prevention therapy is often either ineffective, unsafe, not prescribed, not continued, used wrongly, or rejected by patients or physicians. We can do much to improve our ability to select the patient and select the right therapy. Importantly, we can treat the comorbidity, and increasingly we're interested in how we can treat any atrial cardiomyopathy. But there are 3 major, relatively new treatments. More effective anticoagulants, such as abelacimab or milvexian, a reduction of AF burden, which I've already described with ablation techniques, or left atrial appendage closure or excision. These, either in alone or as part of a hybrid therapy, are the modern context of the evolution of prevention of stroke for atrial fibrillation. And it is in this setting that we want to discuss particularly what happens and how the left atrial appendage closure device is evolving. Thank you very much.
Thank you very much, Professor Kam, for setting the scene for us. You will be able to ask questions for the speakers and the panel here using the app. We can read your questions up here. You pointed out, Professor Kam, some of the major problems with oral anticoagulants, adherence. Do you think in order to get effective drugs, we need some drugs that could actually have a duration of weeks or months? Because apparently it's a very difficult task for us all of us to remember taking our pills and be adherent.
Yes, I think we do need drugs which are long-acting. And some of the new anticoagulants, which are monoclonal antibodies, can be injected, and they'll last for a month. So you can get a month's worth of treatment, and then you can be sure that the next injection is given. So that is a possibility. to have long-acting medication, and that's certainly in the mind of the drug developers of these new anticoagulants. Others are oral drugs that you have to take once or twice a day, but several are monoclonal antibodies, but expensive, of course.
So one of the other options to go for a continuous stroke prevention would be to put in an occluder, because it will be there, and it will be there in the future as well, and there will not be those adherence issues, and it might also solve some of our bleeding problems. So I would say thank you for your presentation, Professor Kam, and then I will invite you, Philip, to speak about LAAC. Is it a safe procedure? Is it an effective procedure? Can it solve some of the problems highlighted by Professor Kam?
Thank you very much, Jens-Erik. Balancing efficacy and safety for left atrial appendage closure. These are my disclosures. As you know, left atrial appendage closure is a one-time procedure. It's a one-time implant that do not need to be replaced. It's a minimally invasive procedure that we can perform under general anesthesia or a cath lab EP suite by a heart team. The average time procedure has been 1 hour. It's now less in many centers. And the average hospital stay has been 1 day. And it's now performed as a same-day discharge procedures in many centers. You all know the Watchman. That is the most common and the best studied device for left atrial appendage closure. More than 10 years experience with Watchman, so we have a lot of data, we have a lot of studies, and that will be my task to go through these studies. As we mentioned already, more than 500,000 patients have been treated with Watchman. And as you can see from the Pinnacle Flex study that was performed in 2018, we can see that the safety endpoints was crucially low and very reassuring with Watchman Flex. Only 2 patients on 400 had an ischemic stroke. No all-cause death, no embolism, no device or procedure-related major events. What about the efficacy? You can see that peri-procedural adverse events were far less below the performance goal that was expected in this trial. We had data from Surpass Pro, and you can see that with Watchman Flex Pro, the events were very similar at 45 days to what we had with Flex in Pinnacle. So very low rate of events, less major bleeding. We will potentially discuss why, but this is very reassuring regarding the use of Watchman Flex worldwide. So what about Watchman Flex Pro? I mentioned, you know, that it's the last generation of Watchman Flex. The HEAL LAA study was performed to show about the primary safety endpoint. You can see the composite of all-cause mortality, all stroke, systemic embolism, and major bleeding at 6 months. And this safety endpoint was far less below the performance goal that was expected to be 21%. It was less than a half of that. And it was very, very similar to that we observed with the Pinnacle Flex study. More recently, we had the results of the OPTION study trial. You know that the OPTION study is a major trial involving 1,600 patients treated with AF ablation and then who were randomized to Watchman Flex or to oral anticoagulant with a follow-up of 3 years. The primary efficacy endpoint was all-cause death, stroke, or systemic embolism, and the primary safety was non-procedural major bleeding or clinically relevant non-major bleeding at 36 months. This is the efficacy that we observe in the 2 arms, and you can see that the non-inferiority was met with Watchman, 5.3% rate of composite efficacy endpoint at 3 years compared to 5.8% with anticoagulant, with DOACs. So this is very reassuring that in the modern era, with the most modern drugs that we have, in a context of a randomized control trial where pills are given and counted in every patient, that the device do as well as the latest generation anticoagulant. What about safety? You can see that the number of bleeding was half with Watchman compared to patients treated with anticoagulants, which is, I would say, very surprising to me, because these patients were not high bleeding risk patients. They were low bleeding risk patients with a Hasbled score of 1.2. So even with these patients at low bleeding risk, the difference between Watchman and anticoagulation was very, very significant at 3-year follow-up. And then we had the good surprise that these efficacy and safety endpoints were still consistent across all subgroups of the trial. What about whatever patient's age, sex, Schatzva score, Hasbled score, AF type? Every single patient, every single group at least benefited from the trial. So in this context, we had last week in AHA the Closure AF trial that was presented. And what is the Closure AF? It's a randomized control trial that was driven and conducted in Germany and Europe, where patients with a Schatzva score more than 2 at increased bleeding risk because of a Hasbled score more or equal 3, a history of bleeding, or very severe chronic kidney disease, were randomized to catheter-based left atrial appendage closure or to physician-directed best medical care. And the primary endpoint of this study at 3 years was a composite of stroke, systemic embolism, cardiovascular death, or major bleeding. So the community was surprised that in this trial, the left atrial appendage closure procedure failed to meet the non-inferiority compared to best medical treatment. And we have to say that in this group, more than 80% of the patients were treated with DOACs. So we don't want to hide behind our finger. I think we have to talk about that, and we have to better understand what happened with the trial. There's a lot to say and to learn from this trial. And I think interpretation of the trial should be very cautious. We don't have the study published at the moment. We just had preliminary results that were presented during AHA last week. So we've heard that, yes, the trial might be underpowered. The rate of peri-procedural complications rate was far higher than it is in contemporary practice and trials. But to me, what is obvious is that in this trial, highly selected patients were recruited. These patients were far older and sicker than patients that we treat in real life. And if you look at the annual mortality rate in these patients in this study, it was 15% per year. So these patients were not consecutive, just one number. The number of patients recruited per year and per center was 1.5. So these patients were highly selected, high risk for procedure, and this is probably what was the problem, what was the issue, what was the difference with different trials that I previously mentioned. I think it's very helpful to go through that. It will probably help us to identify patients who fail to derive benefit from the procedure. This is what we called futile in the field of TAVI, and we here at the PCR London Valves, we know that we had a lot of futile TAVI in the past, and we were very, very dedicated to find a good population that benefit from the procedure. And I think that with closure AF, we have a futile LAAC population. So that being said, what are the mechanisms underlying higher efficacy and safety across patients and in our procedures and practice? I think pre-procedure imaging and intra-procedure imaging are key, and really in the modern practice and in our hospital today we have a lot, and we have learned a lot from 3D imaging and multiple planar reconstructions. We learn a lot together, we share knowledge, and we have a lot of meetings like this one today to share best clinical practice and to learn one from the others. Of course, we have device technology and delivery sheath technology that helped a lot, decreasing the number of procedures. And finally, we are shifting away progressively from general anesthesia with mini probes and with ice and patients in conscious sedation. So now, I think that LAAC is nowadays a safe procedure in line with modern interventional cardiology like we do with PVI, with PCI. It's a same-day discharge procedure in ambulatory care sensitive units. And it's a procedure that we would like to expand through concomitant therapy. We talked about PVI, but also TMVR. We had a great nice case in Main Arena 1 hour ago. TAVR patients may benefit from that because they have high bleeding risk, and more than 1/3 of them have AF. In summary, I think that we can say that LAAC with Watchman is both safe and effective procedure. We have a number of very important trials with a large number of patients. As you know, the number of cases have grown at an astounding rate, especially in the US, and it's increasing now in Europe. In this context, I think that closure AF should be interpreted as a signal to better stratify clinical indications and avoid futile LAAC in patients with a low expected life expectancy. Of course, operator skills, imaging, next generation, new generation device and delivery sheath technology have substantially contributed to higher efficacy and safety. And nowadays, a post-implant antithrombotic regimen is evolving to a simplified regimen, thanks to the work of Jens-Erik and Kasper especially. And this has to be adapted to patients' bleeding and thrombotic risk. Thank you.
Thank you very much, Philippe. I think we will have to move on because we're running out of time already. Having said that, let me introduce our next speaker, who is Kasper Korsholm from Aarhus in Denmark, and he's going to tell us why anticoagulation isn't always enough. Kasper.
Thank you, John. Okay, these are my disclosures. First of all, as John already mentioned, we know that DOAC is not perfect. The efficacy and safety is already established, but we also know that the risk of stroke despite of anticoagulation is around 2% per year. This is from the randomized studies. So this is in a controlled randomized setting where we control that the patients actually take medication. So it might be even higher in real life. And as you see on the graph, it depends on the vascular risk profile of the patient. But the strongest predictor of stroke and recurrent stroke is having already had a stroke, and that's regardless of whether it's on therapy or whether it's the first presentation of atrial fibrillation. You see that the two lines up here are patients with prior stroke history, and it's regardless of the CHA2DS score. We also know that patients with a history of stroke are at increased risk of major bleeding events. This is also from one of the randomized DOAC trials, and we see it across the other DOAC trials as well. So these patients may particularly benefit from other therapies or add-on therapies. And further to highlight that, we see from stroke registries, on the left-hand side you have from Swiss stroke registry, where 21% had pre-existing AF diagnosis upon admission. And on the right-hand side, you see Danish data from our Danish AF registry from 2024, that 65% of patients admitted with a stroke and AF had redeemed a prescription of anticoagulation in the 3 months before admission. So why do these patients experience stroke? And as John also mentioned, some of them is due to insufficient anticoagulation, wrong dosing, compliance issues, or that we stop DOAC due to interventions and so forth. But quite a significant proportion have competing risks or an embolic stroke despite of anticoagulation. And we know from the studies that changing the strategy or adding antiplatelet therapy or increasing the RNR value doesn't help anything. It does not modify the risk of recurrent stroke, and it's strongly discouraged in the guidelines. Then the LAAC trial, despite being a surgical trial, it actually taught us quite a lot. And for many years, we've been citing imaging studies saying that the left atrial appendage is the nidus for thrombus, and it is. But the LAAC trial highlighted that the left atrial appendage has a causal role for AF-related strokes. So eliminating the left atrial appendage decreases stroke risk, and here by 2.2% in absolute risk reduction after 4 years of follow-up. But we do not know whether it's patients have to continue anticoagulation or whether it's regardless of anticoagulation. This is a sub-study from the LAAC trial showing that the benefit of left atrial appendage occlusion surgically was consistent regardless of DOAC use or not. We also have some observational data. These are from European sites, left atrial appendage occlusion, and they were propensity matched to a cohort receiving anticoagulation, primarily DOAC. And there was a comparable, see over here, comparable stroke risk. This is from the Danish study and the Unmet observational registry. And on this slide, you see patients with stroke on therapy where there was a huge benefit of left atrial appendage occlusion. This is observational data. I think one of the main questions, and I think Apostolos will also go into that, is how should we treat these patients after closing the appendage? And if we look at other trials in secondary stroke prevention, we have the ESIS trials. All 4 of them showed no benefit of DOAC therapy when there is no atrial fibrillation. And so perhaps we could actually leave patients on aspirin after closing the appendage because we believe that we take AF-related strokes out of the equation. And what we see is that many people cite that the bleeding risk on DOAC is comparable to aspirin, and I don't believe that's true. We have data from the Artesia and NOAA AF trials and subclinical AF, significantly increased bleeding risk. The hazard ratio of 1.6%. 1.6, so 60% increased major bleeding risk on DOAC compared to aspirin. And despite not being significant, when you combine all the ESIS trials, the hazard ratio is completely the same, 1.6. So I think that DOAC will likely cause more bleeding than aspirin therapy. So to conclude, I think these patients having stroke, regardless of whether it's on therapy or whether it's a history of stroke without DOAC therapy or anticoagulation, there's a huge question, how should we actually treat them? Should it be DOAC continued? I don't think that is a good solution for those having failure on stroke on therapy. Should we combine a left atrial appendage occlusion with DOAC, or should we combine left atrial appendage occlusion with single antiplatelet therapy? Luckily, we have 4 randomized trials ongoing, and we should include patients and randomize them so we can get good data to support our continued strategies. Thank you very much.
Thank you very much, Casper. Just one quick question. Are you then advocating for a hybrid approach, anticoagulation plus LAAC or LAAC alone in patients that don't tolerate or don't take anticoagulants?
I would advocate for left atrial appendage occlusion in combination with a platelet inhibitor, because I think then patients are covered for the AF-related strokes, and we do not have any studies showing that if you do not have AF, there's a benefit of DOAC. But leaving them on a platelet inhibitor will cover other causes like small vessel and large vessel disease.
Thank you very much, Casper.
Thank you.
Let's move now to our next speaker, who is Apostolos Tsikos, who is from Thessalonica in Greece, and he's going to talk about post-procedural medication pathway. Apostolos.
Thank you. I'm very glad to be here with this exceptional panel, and I will try briefly to talk about what we do after LA closure. But before doing that, I just wanted to present to you a slide I presented in TCT 2016. At that time, talking about LA closure, we're worried about complications. And I think we still need to know the device that we're using. We still need to master the technique. And of course, we need to know the patient. But the topic I will talk about is more to do with the patient itself or herself, himself or herself. Right now, we're talking about performing an optimal LA closure. We're not worried so much about complications. And we need to look carefully and to understand what is the patient we're dealing with. This is a case. I was asked to do LA closure. The patient is under general anesthesia. This is how this patient looks when he's asleep. And then we increase the heart rate, we increase the blood pressure, and you have a totally different image. So there are still many things to learn for each individual patient. And the patients are not the same. Medicine sometimes, at least in the ancient times, was considered art, and this is sometimes the indication here, the scenario here, because when we offer these patients stroke prevention strategies, they come from all over the place. And I will briefly present to you what we think about when we talk, when we decide what to do after LA closure. So it depends. Did the patient have previous bleeding? Was it minor, major? Did the patient have a stroke on anticoagulation? This is a totally different patient population. Did he have a thrombus? Or based on the history, does the patient have another reason to take antithrombotic therapy, like coronary artery disease or deep vein thrombosis? Is he or she compliant? The anatomy is very important. The appendage and the heart has a very variable anatomy. We may have a dilated appendage, dilated left atrium. We may have spontaneous echo contrast that you saw before. We may have mitral regurgitation, low ejection fraction. So every patient has its own or her own characteristics. The implant quality is very important. It depends. The medication that we will give later on may depend on the per-device leak, or it may depend on the device size that we have put. And finally, there are some regulatory and guidelines issues, because if you choose not to prescribe the per IFU or per regulatory requirements medication, you may face some questions later on. So, and these are the options that you might give later on. It's all over the place. So far, I have more questions than answers for you. There are a few things that we have learned. We recently published this meta-analysis based on data from several studies and showed that a leak over 3 millimeters is not benign. So if a patient has a leak of more than 3 millimeters, we need to reconsider our anticoagulation therapy and antithrombotic therapy later. And the second part is the device-related thrombosis. Partially, this was related to the definition of what is the DRT. We now know that the left side of the image, based on the work of also of Jan Zerik, is not DRT, is healing. And we have learned that we should not do very deep implantation of devices, because what we have seen in studies is that we may expose the patient to less flow conditions, and we have a thrombus. That being said, there is new technologies coming up. The Watchman Flex Pro with a special coating on the PTFE that, at least in animal studies, has shown superiority for the clot formation on the device and the DRT, as you see here. This remains to be proven, of course, in larger studies. In the meantime, I will just show you this meta-analysis that was just accepted in European Heart Journal about this particular topic. And we investigated approximately 70,000 patients in several studies, and these were the eligibility criteria. And the outcomes was major bleeding, thromboembolism, DRT, and all-cause mortality. So 49 observational studies and 3 randomized clinical trials. And this is the comparison between low-dose NOACs versus other options with these 4 outcomes. And this may look like a busy slide, but I can tell you that the take-home message and the final considerations, the results, the conclusions that we had, is that we have a trend towards DOACs, and the trend is towards half-dose NOACs as the best option. But still, there are things for us to learn, and hopefully the results of the Simplify study that is now running, sponsored by Boston Scientific with Watchman Flex Pro, will give more definite answers to this question. But what is very important is to go from numbers to individual patients. This is all about modern medicine, I think. Thank you very much.
Thank you very much, Apostolos. A quick question again. You say low-dose DOAC following implantation of an LAAC. Does it matter which DOAC?
The more data we have is with apixaban. But the trend was the same in different kind of DOACs.
Thank you very much. So let's move now to the last of the formal talks, and that will be given by Jens Erik, who's from Aarhus in Denmark, and he's going to talk about perspectives from the international guidelines. Over to you, Jens Erik.
Thank you very much. So we have guidelines, we have ESC guidelines, and we have US guidelines. The most recent ESC guidelines is from 2024, and as you can see, we do have a class 2B level C evidence recommendation, and it's not a very, very strong recommendation in the ESC guidelines. And it's addressing patients that have a contraindication for long-term anticoagulation, and they may be considered for LAA closure. So the low level C is probably related to the fact that we still need more randomized data, and we have many trials coming up in near future. If you look on the American guidelines, they are more liberal. They are also addressing patients that have a contraindication to long-term oral anticoagulation, and they recommend left atrial appendage occlusion with a 2A classification level of evidence B, and they use the phrase is reasonable to do LAAC. They also address people that do not have a strict contraindication but that have a high risk of bleeding and consider LAAC as a reasonable alternative. We do have abundant new data coming up, and you can see during the years, this is a number of publications about LAA closure, and there's really a lot of observational study, but there's also an increasing amount of randomized clinical trials, so hopefully we can get a stronger recommendation in upcoming guidelines. There's also a new 2025 US guideline coming from SKY and Heart Rhythm Society, and you can see here that if you have AF and a contraindication, the panel here also suggests LAAO, but you have to involve your patient. You have to explain the patients about the risks that are with the procedure and also the risks that are related to all contraindication. And also those guidelines consider LAAC as an alternative to all anticoagulation, just that you have AF, and even though you are able to tolerate OAC, it can be an alternative, again, if you want to understand the procedural risks and the risk with anticoagulation. We also have a position paper published in Europace last year. This was a large group of interventional cardiologists, EPs, but also neurologists, nephrologists, and gastro people were involved in creating those more practical guidelines on when to do left atrial appendage occlusion or when to consider it. And you can see that if you have a mild to moderate risk of major bleeds, you have also to be aware of, is the patient actually adherent to all anticoagulation? Is there a failure for this patient? Or is there even in the history also unacceptable bleeding? Or there might be also stroke events during all anticoagulation. And all these factors would motivate physicians to consider LAAC. And especially if you have a high risk of bleeding, and you are predictable not a very good candidate for anticoagulation, you should consider LAAC. And this is a population of patients that we actually treat now. Those are the ones that have recurrent bleeds. Very often we have patients suffering recurrent gastrointestinal bleeding. We have patients suffering bleeding in the brain. We have patients where neurologists are really afraid that they have a lot of microbleeds in the brain. We have patients where we isolate the left atrial appendage and are leaving just a very hypocontractile appendage with a high risk of stroke. We have renal failure patients that do not tolerate DOACs very well. So all these patients are very, very difficult to treat in clinical practice with DOACs, and those are the patients that we actually get referred for left atrial appendage closure and offer this therapy. The guidelines are not at the moment addressing the data that we have from the most recent trials. For instance, you have seen, Philip showed us the option trial data. So this is after ablation. The usual standard way is to go for full dose DOAC after ablation, but there's now this alternative of LAAC where we have proved that you can have the same degree of stroke prevention with LAAC than with DOACs, but you have the advantage of a reduced bleeding risk long term. Here was non-procedural bleeding reduced by 56%. And even though you also count procedural bleeds, there's a major difference in the bleeding adverse events with the two regimens here in favor of LAAC. You get much less bleeding with that concept. We still have trials out there. Closure AF was mentioned. We don't have the full paper yet. We have other papers on contraindicated patients coming up in the future, and especially I want to highlight the Champion AF. It has been mentioned. It's a really large trial, more than 3,000 patients, like a general AF population having CHA2DS2 or 3, and randomized either to Watchman Flex or to DOAC. And this trial will be presented in March next year. So we are very, very close to having the largest trial ever on left atrial appendage closure. And a little bit later, the Catalyst trial, this is with the Amulet device, will follow and give us even then more information and randomized data. I want to highlight this as well because it's a very, very good surgical trial. you see that it's a very large group of patients. There's more than 2,390 patients that comes for cardiac surgery. In addition to bypass or valve surgery, they get closure surgically of their LAAO. And both groups here, the group that have no surgical closure and those that have closure, are on all anticoagulation after surgery. And you can see here that with left atrial appendage surgical closure, they do much better in terms of their stroke risk, because after 3 years, stroke rate was 1/3 lower in the group with surgical closure. So this is now has been transitioned into a class 1 recommendation for surgeons to close the left atrial appendage. And we have the LAAC study running now. We will try to replicate those data with a percutaneous procedure. So this is also a very large trial, 4,000 patients. And again, here you do both left atrial appendage occlusion and on top of this also a DOAC treatment. So this is for the very high risk patients with CHA2DS2-VASc 4 or more. So thank you for your attention.
Thank you very much, Jens-Erik. Why don't you come back to us here, and I think we could start with some general questions. I'm struck, Apostolos, by the fact that the implant rate in the US is very much higher than it is in Europe, even though we had in many ways a head start in terms of using LAAC. What do you think is the reason? Is it because interventional cardiologists are not doing many implants here in Europe, or is it because of any other reason, financing or whatever?
There are several reasons for that. It's a different health system. And Europe, we have different health systems. I think part of it has to do with the reimbursement of medication for the NOACs in the patient population with AF, as compared to zero cost for a patient who undergoes LA closure in the US. But that's a question also for me, to be honest. And especially for the patients that are not adherent or that they are not taking anything and just have a stroke. This is a big question for me. I don't know, Philippe, if you have something else. I haven't answered this question yet. But what I would like to comment, if I may have 1 second, is that we are here in London Valves, and I believe that LA closure is here to stay. And I believe that interventional cardiologists, especially those who do structural heart disease procedures, should be familiar with this therapy. And most probably, you will have to do it at some point in your medical practice, especially younger physicians. I mean, it's growing and it's here to stay. So I'm very happy that we're here in London Valves discussing these topics. What do you think?
No, I agree. I mean, probably the main difference between Europe and the US for the numbers of procedures is driven by the fact that we should we should hear patients, and we should have really in mind that patient choice is crucial. Of course, it's not driving everything. I agree, there's some reimbursement issues, there are finances issues, healthcare organization, but it's a pity that, as you said, a lot of patients have nothing. And we are comparing patients with DOACs to patients treated with the procedure, but in the real life, we have a lot of patients who have no DOACs, or DOACs sometimes 2 times, or something else, and it's really a problem.
I think we are also seeing more and more ablation activity, and that's also part of the discussion, that if you can restore sinus rhythm for a period, that will also help to prevent strokes. But many of those patients that come for ablation, they really have a desire to come off all anticoagulation. They are younger, many of them are physically active, and they are afraid of all anticoagulation. So it has also to do about quality of life, because if you at the same time as the ablation can get your device and get lifelong strong stroke prevention and don't need to think about all anticoagulation, I think that's a major benefit for the patient.
Yes, and recently we have the insights of the LAAC trial showing that in low-risk population, they may potentially benefit only from AF ablation. So we have, and we will probably in the near future understand more what happened in this population. We have a broader spectrum of patients, from low-risk patients. We had in the past CHASVA 0, 1. Now we have a 2. But then in these patients, some of them may benefit from AF ablation as a risk prevention, stroke prevention procedure, at least for few years, potentially. Then the large population of patients having advantage of left atrial appendage closure, and potentially futile LAAC patients, as I mentioned.
Are there questions from the audience? We really must give you a chance. Please, sir, yes.
Can I ask a question to the audience? How many have you implanted a device in your practice here in the room? At least one device. How many implanters here? Okay. 0 devices? 0? Never done? But you would like to do? Okay, thank you. Just to understand. Please.
Right. My question is, what is your approach to somebody with contraindications to OAC, and you do a closure device and then incidental finding of a PFO? Patient who had a stroke.
Yeah, I think this is very clear. Sorry, I will take that. The patient who has atrial fibrillation does not have a cryptogenic stroke by definition. The problem is already on the left side, so I don't think we're justified to do PFO closure unless there is special circumstances. I don't know, Jens-Erik.
No, I think that's the same concept. And I mean, for PFO closure, we are talking about also typically a younger age group, below 65 or below 60, and the typical scenario are they have sinus rhythm and come in with a stroke. But I mean, if you have a younger patient with atrial fibrillation and you have what you could call a high-risk PFO, you probably have to deal with both factors at some time point. And I think we are also moving towards not only treating one, risk factor for stroke. It doesn't make sense. So in the interest of the patient, we really have to also treat things like PFO if it's young age, I think.
Yes, sir. Yes.
The surgical data is quite striking. The surgical data, if you're on and your data, Apostolos, if you're on an oral anticoagulant plus a device, you probably do better than the device alone. And then I'm just struck because a cardiac surgeon once told me that unless you get the device, the entry point absolutely smooth surgically, there will always be a risk. And it just strikes me that maybe we're just dealing with reduced risk. So maybe a NOAC plus device closure offers you the best protection. Then the next phase is maybe a device alone, and then just going down. Because I don't see how aspirin's going to be protective, personally, because it's a relatively low pressure environment and stasis. I'm just hypothesizing here, but maybe the best solution is to have both, if you can tolerate it, and then escalate down.
I'll let everybody else answer it, but just to remember, not all strokes in people who have atrial fibrillation are due directly to the atrial fibrillation. Yeah. So there is a role for aspirin in that sense. But Apostolos.
Well, the LAAC trial was phenomenal because it really told us that the left lateral appendage is a problem. Now, either excise or close it with a device, we have to deal with that now and see how well we can do it. But it's there, and it's randomized, and it's very strong. I don't know if we have much time to talk about it. Jens-Erik,
I think not. I think
I think we have to
Thank you very much.
come to an end, and I just have some key points here, because I hope that you have seen that LAAC can be a valuable solution for AF patients who do not get effective anticoagulation for various reasons. It can be bleeding, non-adherence, etc. And Philip showed us that we now have a procedure that has become very safe and effective, and I believe that it can be compared to what we are doing normally in the cath lab with PCI and PVI as well. And also post-procedural medication, we have learned a lot. We started out with the Watchman device with all anticoagulation in the beginning and quite intensive regimens. But we have data that SAPs and reduced dose DOAC are actually probably effective just to avoid DRT, but we also are awaiting here randomized data. Our ESC guidelines do not give us very strong evidence, but there will be more RCTs coming very soon. And especially also we have the combined ablation LAAC approach, which is not covered in the guidelines, but I think we have a very large, nicely performed randomized trial, the option trial, that have told us that this can be an alternative for patients coming for ablation to get either a combined concomitant procedure or also a sequential procedure, and in that way give stroke prevention. So thank you very much for coming and listening to LAAC. I think this will be hopefully also a topic for the years to come on London Valves, and I think and foresee we'll also see much more combined studies with mitral intervention, LAAC, and also it's relevant for the TAVI population. But I hope you are inspired to go home and prepare for LAAC. It will probably become a very demanding, not demanding, but there will be a lot of requests for this procedure also from patients in the future. So thank you for coming.